recorded. I'd like to start by acknowledging the traditional custodians of country throughout Western New South Wales and their connections to land, water and community. I pay respect to elders past, present and future, and extend that respect and a warm welcome to all First Nations people present today. I'm coming to you from Orange on Wiradjuri land. Tonight, we're joined by a panel of experts in diabetes. We've got tonight myself, Alex Ho, I'm a GP in Molong, Alison Amor, diabetes educator with Marathon Health. I haven't seen Tim Morris tonight. Mark Watson is an apology, as is Dr. Manik Mayadune. However, tonight we've got guest panellist, Dr. Kenrick Blaker, consultant endocrinologist and staff specialist at Canterbury Hospital, who provides a monthly outreach service to Dubbo through Dubbo Medical Allied Health Group and Marathon Health. Tonight's presentation is being given by Louise Thornton, podiatrist in Dubbo. Just a bit of housekeeping. It's important that we maintain patient confidentiality. In small communities, it's often easy to identify patients, and we need to make an effort to maintain confidentiality. Please remain on mute except when you're speaking. We encourage all participants to turn on their webcams so we can see and be part of a community together. You can ask questions in the chat, although we do encourage you to use your microphone. And if you have any questions or IT support needed, please use the chat function, and you can use the raise hand function if you'd like to speak. So a reminder, as always, that our language matters when we're talking about the effects of diabetes. So the words that we use to talk about diabetes affect the physical and emotional health of people living with diabetes. They also affect how people in society view people living with diabetes. Our words need to show that we care and remove bias and blame. People with diabetes may call themselves diabetic. However, evidence shows 1 in 2 people find the label unacceptable and 1 in 4 find it harmful. People with diabetes are free to use whatever words they wish. Other people, especially those of us in healthcare, have a responsibility to engage all people affected by diabetes in positive and helpful ways. At the end of the session tonight, there will be an evaluation. Please hold on and there will be a QR code. And also, if all participants could please just type into the chat their name, their profession, and where they're working or their preferred location, be greatly appreciated and helpful for provision of CPD certificates. And so we'll pass on to Louise for the didactic presentation tonight.
Thank you. Okay. So the first part of the session, I'll focus mostly on neurological assessments that a podiatrist may undertake when seeing somebody with diabetes, and I'll briefly talk about vascular assessments, biomechanical assessments, dermatological assessments, and assessment of footwear. So in terms of an arterial assessment, the client's history is of course very important. Ascertaining if they're a current smoker or if they have a history of smoking, asking them questions about any previous vascular surgeries they might have had. Do they have any risk factors for cardiovascular disease or peripheral vascular disease? And also asking them if they suffer with intermittent claudication and also if they exercise enough that they'll actually develop those symptoms if there's a problem. We would also assess perfusion of the foot and palpate the pedal arteries, dorsalis pedis artery and posterior tibial arteries on both feet, and making note if they are absent, diminished, normal or bounding. So here you can see that the dorsalis pedis artery runs slightly lateral to the extensor hallucis tendon, and then the posterior tibial artery is found behind the medial malleolus. We would then move on to a handheld Doppler assessment and checking those arteries bilaterally again and making note of the number of sounds, the volume and the pitch. And also, if possible, just keeping the Doppler in place for even 45 to 60 seconds, because occasionally you might hear an irregular heartbeat and they're not always evident straight away. And then based on what we would find from our basic vascular assessment, we might recommend further more in-depth arterial assessment. I won't talk about the venous assessment today. And then just a dermatological assessment, just keeping our eyes open for any skin or nail pathologies and paying particular attention between the toes where a lot of pathologies can occur. And then just having a general look at the shape of the feet. Do they have evidence of a high arch foot type or a flat foot? Do they have any digital deformities such as bunions, hammer toes, claw toes or mallet toes? Checking the range of motion of the foot and ankle joints. And just being aware that biomechanical factors can have an overall influence on foot health. So over to the right, the pes cavus foot, you can see there that there's elevated plantar pressures through the heel and the forefoot and the hallux, and that will increase risk of ulceration. And then these are just some off-the-shelf footwear choices, which are very sensible, but again, they won't be suitable for every client with diabetes, and some of our clients will need medical grade footwear or custom made footwear. And you can see on the left where the hammer toe deformity is adequately accommodated within that shoe, whereas on the right you can see that that toe box is too restricted. And sometimes what happens is a client may have a wedding or a funeral to attend, and they decide to wear a shoe that they haven't worn perhaps for many, many years with insufficient toe box depth, which then damages the top of the toe, which can lead to ulceration and infection. And we should also be mindful about the width when checking footwear, and the fact that the foot will widen further when weight bearing. Okay, sorry. Certainly a podiatrist is a very important member of the team in managing patients with diabetes and foot deformity. It's always best to choose a shoe that fits well first, and to avoid any modifications if possible. However, there's certain very basic modifications you could do if there was an area of irritation or high pressure developing, such as just cutting a simple cross through the shoe if you didn't have an alternative like a healing shoe or a prefabricated walker available. And you can see on the slide there that there has been a balloon patch applied over the fifth digit. So in terms of neurological assessment, it's about questioning the patient if they have any symptoms of peripheral neuropathy, and then using the monofilament to check 10 sites on both feet, and then using the tuning fork to check for vibration perception. It's important to just be aware about diabetic peripheral neuropathy, and that it follows a very specific pattern of neuropathy, in that it's symmetrical and distal, and it's often described as a stocking and glove type presentation that may move proximally with time. As you know, there are many other conditions that can result in peripheral neuropathy, and this is just a very short list of some of those. that may mimic or may coexist with diabetic peripheral neuropathy. We should also consider foot and ankle entrapment neuropathies, where we may get sensory loss depending on which cutaneous nerve is innervated. And an example of that in the foot could be something like tarsal tunnel syndrome, where the posterior tibial nerve may become impinged and result in some sensation changes to the bottom of the foot. We also have to consider spinal nerve pathologies, such as nerve root compression, radiculopathy, peripheral nerve root lesion, and again, the sensation loss will depend on which spinal nerves are involved.
So do any participants have any questions about the didactic presentation or clarifications you'd like? I might start off while everyone else thinks, because I wrote one down. Louise, what do you think are the like the essentials for a general practitioner or a practice nurse to do when they're looking at, say, a diabetic foot assessment in the general practice clinic, and maybe for somebody who's not yet engaged in podiatry? What do you think the most important in a limited time and limited resource setting?
Well, I think in terms of the neurological assessment, definitely undertaking testing with the monofilament and the tuning fork, trying to palpate pedal pulses, and also just visually getting some clues about if the person has adequate circulation or not. And just, always checking between the toes, keeping an eye out for any signs of obvious foot deformity. They're probably the main things that I would keep an eye on. Any skin or nail lesions are important to note as well.
Thanks for that. And I had another question that maybe a little bit more, detailed. But is there any difference or advantage to when, say you're thinking there's a arterial supply issue, and looking at, for example, ABI versus ATI, or sorry, TBI, sorry, measurement for vascular supply? So just what you've got available.
Well, Alex, sorry, did you mean like an ankle brachial pressure?
Yeah, ankle brachial or toe brachial.
Yes, I think if you can undertake those, that's excellent. And perhaps in terms of the ABIs, there's a lot of talk about them not being that accurate because of the issue with medial calcification of arteries in people with diabetes, which may falsely elevate the ABPI. And that being said, a low ABI is still a low ABI. So I think there's still some value in doing them, even though, we acknowledge that a normal ABI isn't perhaps as helpful as a low ABI. We always know a low is a low one. And then the toe pressures would be very helpful, because my understanding is that you don't get the calcification of those vessels.
Thank you. Any other questions from the audience? If you're not feeling confident to turn your camera on or your microphone on, you can just type it in the chat and I'll read it out for you as well. It seems that,
I might
yeah,
ask
sorry.
one quickly. Yeah. Louise, do you have anything that you let patients know to keep an eye on in between assessments that they can sort of do in terms of foot care, or any provision of handouts or paperwork that they can sort of do in between, so that if they notice something, they can sort of come present to their healthcare professional or yourself as a podiatrist in between time?
But we have a general diabetes and podiatry education sheet, which talks about the activities that are recommended every day for somebody with diabetes to undertake, and what they should look out for and act promptly. What things to keep an eye on, and if they notice these things developing, then they should see their doctor or a podiatrist or a diabetes educator.
Anything particular on the handout that you have?
Well, it's things about, daily foot checks, footwear recommendations for people with diabetes, what to do if they develop a wound on the foot or if they have a break in the skin, the importance of stringent blood glucose control.
Thank you.
I believe if you are looking for handouts, the NADC website or footforward.org.au does have some links on for both health professionals as well as for patients. And I think if you actually call them up, they post out some flyers and things like that for you if you think that would be helpful, particularly posters to hang up in the waiting room. And they've got another one.
I probably can hear better without it. Oh, okay.
All right. Looks like we might have skipped ahead to the end of the case study there, Ali. But I think we're ready to get going.
I think there might be a question in the chat, Alex.
Oh, yep. Sorry, did not see that. So Shruti, our stellar registrar, former registrar has asked, what will be the early warning signs for a patient or GP to look for in diabetic neuropathy patients?
Well, it could be changes in their sensation. It might be that they're reporting perhaps numbness, tingling, or burning sensations in the feet. And then when you go to check perhaps with the monofilament or the tuning fork, you may be able to identify a deficit there.
In my experience, another one I often get is really ticklish. Is that something? I don't know. It's just something I've observed. Like they get super ticklish on their feet.
Look, you might be correct. I haven't really noticed that, but that's possible.
All right. I'll leave that one as a comment, maybe. All right. Thanks, Louise. I think we're ready for the case presentation. And Amanda Taylor has just also mentioned the Foot Forward has a A4 handout, and I've just copied and pasted the link to Foot Forward there in the chat as well.
Thank you.
Al, just might see if you can give us a summary of the presentation tonight.
Thanks, Alex. So just in summary of the case, Louise presented a case of a 75-year-old female who lives alone and has adult children close by, has previously been very confident with her management, but has had somewhat deterioration in her health over the last period of time. She's had increasing falls, and the last one quite serious, that they had challenges mobilising her and requiring ambulance support. Her HbA1c has been reducing, and she's managed with optician in the evenings of 50 units and Jardiance. She's also been having dizzy spells. She's seeing the podiatrist for a unilateral sensory deficit, which may have causes other than her diabetes contributing to it. However, given that she's overwhelmed with a number of health conditions at the moment, she's not keen to further investigate that. Her main concerns at present are her challenges around sleep, mobility, pain, and our concern is the diabetes management as well. She's not quite as concerned with that. She's, as a result of her poor sleep, she's also really fatigued during the daytimes, and she's less active and getting deterioration of her muscle strength, which is contributing to less exercise and then less confidence to go out. And it's finding it more difficult to get to appointments and mobilise with her frame. With her pathology, there was not too many anomalies except her, with her cholesterol profile, although it would be good to do a general workup and check her thyroid level as well. But on discussion with the group tonight and also with the panel, some of the potential interventions that might be of value would be exploring the sleep situation, having a look at her sleep hygiene and also potential other causes, such as a sleep study. Also, whether she was, with her pain, whether it would be worth considering some medications to support her pain, but if not, potentially non-pharmacological strategies such as physiotherapy, which would have flow-on effects for her general well-being. In terms of her sugar levels, there's concern around her frequency of hypos, which is putting her at risk, and a CGM might be of value to understand what that profile looks like, and there might be merit in having a discussion with her around tolerating slightly higher sugars and reducing her medications to keep her safe. And it was also mentioned that it might be of value to do a bone density scan as well, given that she is at high risk of falls and potentially fractures. So I think that's all I've got. Is that a reasonable summary, Alex? But thank you for everyone for their contribution.
How to compress an hour into 2 minutes. Wonderful. So you'll all see on the screen there's the QR code for the evaluation for tonight's session. Strongly encourage you to complete it and to receive your CPD points. Invitation, as always, please send in your cases. We're always looking for presentations and presenters. If you wish to volunteer a case, it'd be greatly appreciated. Just contact Ali Sullivan at the PHN or Katie Pryor. I'm sure we'd also be happy to help out. And we're very happy to help support you. If you've got a case and you're not sure about it, you just reach out and we'll help navigate the process. Our next session is in October 17th, also a Thursday at 7 p.m. I'll have a didactic from Ajuri Valagala. Apologies if I'm pronouncing that incorrectly. She's a dietitian talking about abnormal nutrition. So important topic. Thanks again for coming along tonight for this ECHO session. We look forward to your attendance next month. I just ask the panelists to just stay on briefly for a few minutes afterwards. Thanks. That's pretty much it. Any comments? Any concerns? Went okay, I